We share all of the best info available up to date, sometimes even before it's available for common use. So we're super excited to have you guys back for another amazing show and an amazing week. And we're going to be chatting about a really important topic, which is recurrent implantation failure. There are new guidelines that are available from the Canadian Fertility and Andrology Society being published in Reproductive Biomedicine Online. So I'm going to review some of that with you. We're going to talk about where we agree, where we disagree, what the evidence shows, and that way you guys have some interesting info to help arm you as you move forward on your own journeys. So we always take the first couple of minutes of the show to just chit-chat while everybody's logging on. I can see some of our favorites jumping on there, and we'll chat with you guys about all your questions. As always, ask them. And the earlier you ask them, the easier it is to get them answered, because we do flip back to the start of the question reel when we start doing our live question and answer session. So if you have questions, don't hesitate, go ahead and ask, and we'll definitely make sure we get to those as we go through the show. So hopefully you guys have all had a good week. I hope that you are all making sure that you are self-isolating, using your masks, still using your hand sanitizer. It does very much obviously look like we are experiencing a second wave. And because of that second wave, we want you all to be super duper careful. So make sure that everybody is doing everything they can to be cautious. Make sure that you and your family members are all being very cautious about all of those things. And especially if you have little ones and they're going to school, those little guys and girls are bringing home tons of COVID. So that's really, really important to make sure they're staying clean. Shower them when they get home. Make sure that you are getting their hands clean, and be really cautious with anybody that has any signs or symptoms. That's really important. Lots of people have been really worried recently and wanting to rush to get their IVF done before there is a second wave. So, it's really difficult to rush IVF. Second wave or not, that's never a good idea, because it's just a waste of money. So I do not recommend you go blazing in to do your IVF cycle just because you're worried about a shutdown. There is no mention of any shutdowns right now. So we definitely have had some talks about it. The Canadian group has sort of sent around some emails discussing possible scenarios, but no one has at the moment suggested that we need to shut down or that we even will shut down. So that is certainly not on the horizon anytime soon. So don't be panicked about that yet, guys. There's lots of opportunity to help everybody out before we get to that kind of scenario. And so we're hoping to avoid that for sure. And hopefully everything will go well. I do want to send a huge amount of thanks to my whole team here at our fertility center, including the Pattinson Clinic, Dr. Anthony Pattinson and his amazing team with his wife, Mary, his nurses and his front desk, all of whom tremendously helped us to get through our inspection with flying colors. So we're really happy about that. And many thanks to all of you who contributed. I'm totally blessed to be working with such incredible people here. So thank you guys, and to my own team, of course, for all the work that they've done up to now and continue to do every day to help make these journeys come to life. Lots of interesting things going on. We've been talking to lots of our donor and surrogate agencies and trying to make some really interesting things happen for people. So that's got some interesting news that'll be on the horizon shortly. And we're working on a couple of new interesting projects in that domain as well. So hopefully we'll be able to serve you all in many different ways. Okay, so the topic today is recurrent implantation failure in IVF. And this is the Canadian Fertility and Andrology Society Clinical Practice Guideline, published in Reproductive Biomedicine Online. It's actually not out yet. So this is in their advanced articles section. You can access it if you just download their app, and that's where I get them from. So all you got to do is download the app and then you can go from there. Okay, so the first issue that we deal with in recurrent implantation failure is that absolutely nobody agrees on what recurrent implantation failure is. Is it 2 transfers? Is it 3 transfers? Is it 6 transfers? Is there an age dependency in there? What if you've had fresh versus frozen? So nobody agrees on this. And because of that, every study has different criteria. And so there is no uniform definition of what constitutes recurrent implantation failure. To me, it actually very much depends on your center. If your center has really good success rates, maybe recurrent implantation failure for your center is 2 or 3 embryo transfers. If your center doesn't have great success rates, and many centers don't, some centers have a 30-35% live birth rate for their IVF program. If that's the case, you may need 2 or 3 cycles of IVF before you get to the point where you would call it a recurrent implantation failure. So it's center dependent, and I don't think anyone's ever going to come up with like a uniform definition, because it's impossible to apply what you get in one center to another center. So if we look at some of the best centers, if they're just doing it after 2 embryo transfers or 3 embryo transfers, that's going to be very, very different from a center that needs to go through 2 or 3 IVF cycles where they may have 6 or 12 embryo transfers. So very, very different results, very, very different criteria. And so you need to know that when you analyze this kind of study or this kind of data. Okay, so I'm going to pull it up for our friends on all the social media formats that are not Instagram, because you guys can see it. For everybody on Instagram, I'm going to be reading out some of the stuff to you. Okay, so the first thing they looked at was cavity assessment. So should we be investigating the inside of your uterus for its shape, pathologies like polyps, fibroids, scarring, which can lead to recurrent implantation failures? And the answer was, they looked at hysteroscopy, and there was a study called the Trophy study, 350 women with 2 to 4 previous failed IVF cycles. And they looked at half the group that had hysteroscopy versus the group that did not have hysteroscopy. So in that study, they did find anomalies in up to 24% of the women, but for some reason they said that they couldn't actually operate on all of them. Only a small percentage were operable. They said only 4% was operable. Now, is that because they couldn't do it during the hysteroscopy because it was in office or because of the skill of the surgeon? They don't clarify. But certainly, you know, in the hands of an expert, if you see something at hysteroscopy, it would be kind of crazy not to deal with it. And if you're good, you should have no trouble dealing with it. So whether it's a T-shaped uterus or a septate uterus, Asherman syndrome, fibroids, polyps, I mean, I deal with all of that stuff all the time. And very soon, we're going to be actually having our own hysteroscopy facility here on site in the office. So we're really excited about that opportunity, assuming the government gives us the billing permission to do so. We'll be moving it out of the hospital so we can help you folks out a lot sooner than we can right now with COVID and the hospital situation. So bottom line was, they said that for hysteroscopy, there was no benefit to doing it because they found the same results in the group that had the hysteroscopy versus the group that didn't. Now, again, not a great study because they weren't dealing with the pathology that they found, even though they actually found it in 24% of the people that, that were evaluated hysteroscopically. They don't, however, discuss anything about the saline infusion sonohysterogram. And you really can't justify not doing a saline infusion sonohysterogram. Done properly, and we have a great YouTube video where one of my favorite patients showed the actual process. We videoed it, doing it on her live. She's not complaining of any pain. She has no discomfort. We get a great image from it. It's super easy to see. And if done properly in the right hands, a saline infusion sonohysterogram is painless, effective, gives you tons of information, can show you if there's any abnormalities in the uterus, and really should be part of that RIF evaluation, but they don't include it here in the guidelines. So that's the first one. Let me scroll up just to show you guys where we're talking about this. So this is the very first one. shows you right here where it says that cavity assessment, not really important. So the second one they looked at was thrombophilia screening. So thrombophilia screening is where we check you to see if your blood is thicker than it's supposed to be. Some of you may have heard of this with factor V Leiden, antithrombin 3 deficiency, methyl tetrahydrofolate reductase enzyme deficiency. So there's all sorts of different anomalies. The lupus anticoagulant or antiphospholipid antibodies. So the largest study they looked at was pretty old now, about 8 years, 594 women who underwent up to an average of 7 failed IVF cycles. So 7 whole IVF cycles, kind of crazy. I would never even do that many on a patient. So they looked at those who were tested and were treated with anticoagulation versus those who were tested and not treated, and were treated with anticoagulation. None of them had a prior history of blood clots. And again, they did not show a significant association between the clotting disorders and the outcome. So they said testing for it doesn't help. They do later on talk about treatment for it and say that treatment for it actually is equivocal. They can't tell for sure if it works or not. So right now they say it's a research setting question. So I'll get to that in a minute. What else about testing? They looked at immunological testing. So what about doing immune testing to see if that's helpful? So these are those really expensive tests, usually somewhere between $1,500 to $2,500 Canadian to test for the natural killer cells. Many of you will have read about CD56, the T helper cell 1 to T helper cell 2 ratio, all of the interleukin levels, complement levels, and so on. So in this case, they say that it should be limited to research settings because, and you can see it down here, recommendation number 3, because they're not sure. They're saying that there is alterations in the immune profile, and you can see it in the write-up here. It says several serological immune profiles may play a role in patients with RIF. Antibodies against placenta-specific 1 protein may impair implantation, have been shown in a small case control study to be associated with recurrent implantation failure. Same thing with interleukin levels, interferon gamma levels, all sorts of different things, transforming growth factor beta. So there are some levels in proteins and chemokines and so on which may be associated, but they're not sure. And so they're saying maybe it's worth it, maybe it isn't. If you talk to reproductive immunologists, like my great friends Fred Zineku and Chloe Romain in Toronto, amazing pair of reproductive immunologists, they will tell you that in certain circumstances, this is really important. I know I send my patients to them when we're thinking immune stuff, and they find stuff sometimes, and then we address that appropriately. And with their sort of protocols, they are seeing very, very high success rates in populations where most people are seeing very poor success rates. What about genetic testing? So this is the karyotype analysis. This is a no-brainer. If you have recurrent implantation failure or recurrent pregnancy loss, you need to be tested. Why? Because a certain percentage, albeit low, but nevertheless present percentage of patients will have abnormalities, especially translocations or balanced translocations. And when that happens, you need to have the appropriate treatment, which is actually specialized IVF with pre-implantation genetic testing for balanced translocations. And the Korea Fertility Clinic I work with in Toronto just pioneered a new technique where you actually can see which ones actually carry the balanced translocation versus which ones are normal. So there is some really amazing work going on out there, and kudos to Dr. Librak who came up with that with his team. Okay, what about sperm DNA fragmentation testing? Well, no one's ever really shown that DNA fragmentation testing is associated with recurrent implantation failure, so it's not recommended for that, but we do recommend it for couples who have unexplained infertility, and we recommend it for couples who have problems with recurrent miscarriage, because it is a huge increase in your miscarriage risk if you have high levels of DNA fragmentation. So DNA frag is more and more becoming mainstream. I still don't believe it's indicated for everyone. If you've got perfectly normal sperm, you probably don't need to do it. But for everybody else, if there's sperm compromise, history of recurrent miscarriages, you need to consider doing the DNA frag because it will potentially make a difference for you. So those patients need it. What about doing chronic endometritis? So chronic endometritis is, again, very complicated. This is inflammation or infection in the lining of the uterus. The criteria for diagnosis, again, does not exist. No one agrees on what qualifies for chronic endometritis. So it's really hard to know if they're making a difference or not. So the results from this one, they said there are no trials that compare treated versus untreated. And they did see several studies that showed sort of very small results, and they say they're very susceptible to bias, although there is one big meta-analysis that suggested that there was a benefit. So again, they say it should not routinely be offered. I do take an exception with this, and that is that this is looking at chronic endometritis where you biopsy the uterus and you're looking at pathology. We know that that can miss actual infection in up to 50% of cases, if not more. So the real way to do this is to actually look for bacteria or viruses in the lining of the uterus. We now use a company called Fertility. It used to be called Locus Medicus, which is out of Greece. I own no stock, as usual. I always have a disclaimer. I don't work for any company but my own. So they have a website, www.fertilylys.com. Their test is called the Hidden C, and they have a 12-in-1, and then you add on HHV6, which is human herpes virus 6 to the equation. So they can actually test for the presence of the RNA from the bacteria, viruses, yeast, all of that stuff, and look for it in the endometrium simply by sampling your menstrual blood. And that's a really valuable test because if there is infection in there, that has all sorts of risks for failure, for complications with, your growth of your embryos, for miscarriages, and even late miscarriages where we've seen women that have had, results where they'll deliver their child at 18 weeks, 19 weeks, 17 weeks. I just did that not too long ago for a patient that very tragically suffered a 19-week loss. And she had not just one, but 3 different bacteria in her uterus, which we needed to deal with. So all of those are really important. So I do disagree with this statement. I think that chronic endometritis testing maybe isn't that valuable, but testing for bacteria is. What about the ERA test, the endometrial receptivity array? So they say here that it's only usable for research. There's minimal data to support it. And within the last week, there were 2 more studies that have demonstrated absolutely no value to doing the ERA test. So for those of you that are still hung up on the idea that the ERA test actually works, the ERA test is useless. It's been proven to be useless by the company's own study. Multiple other trials have shown that it's useless. It's useless. Don't waste your money on that test. It should only be used when you have really thin endometrium and we can't tell if it's even receptive at all or not. But do not use it to date your endometrium or to alter the timing of your endometrium, because we've reviewed on the show other studies that show that there is no difference in outcome whether you do a transfer after 5 days or 6 days of progesterone for a day 5 embryo, and that day 6 embryo should be transferred after 6 days. So saying that your endometrium is receptive at a specific time doesn't even make sense when you're looking at the receptivity in relation to the timing of the embryo. So skip that stuff. Do not do it. It's a waste of time. Okay, what about pre-implantation genetic testing? Well, they're saying that there is insufficient data. As you know, and we've reviewed this on the show, PGTA testing is not useful for women that are less than 38. But whether or not it's useful in a group where they have recurrent implantation failure is a different question. If you are taking a euploid, in other words, genetically normal embryo, putting it into a patient and they're still not getting pregnant, there's probably something wrong with that patient's system somewhere. It's unlikely to be the embryo at that point. It could still be, but it's unlikely to be the embryo. And so as a result, you really need to take a look at what the possibilities are in terms of problems with the patient, which may mean that you need to actually find a carrier. So I think it's reasonable to consider it in this circumstance, but there's not enough data to talk about it yet. So there's no randomized controlled trials. They then go on to treatments. So what about endometrial scratching? So this is the biopsy. So we've covered this on the show before too. I'm going to keep this short. They say it's insufficient data, but the bottom line is every week someone publishes a study that says, yes, do it. And next week they say, no, don't. So I think the jury is out. They say that the two most recent trials showed that there wasn't a benefit, but after these, there was more data that showed that there actually was a benefit, again, in randomized controlled trials. So I would not tell you to do it or not do it, although aside from the 5 seconds of pain, it's relatively harmless. So if you want to try it, go for it. It certainly doesn't do any damage as far as we know. Okay, what about taking heparin or aspirin, anticoagulants? Again, they say that it should be limited to research for heparin, and the aspirin, they say, is the same thing. It should not be routinely offered. Again, I'm going to say that there is enough data, in my opinion, to support trying it, especially when you've got recurrent implantation failure. It's not easy to just keep telling patients, you know, there's nothing that can be done or we don't know. Sometimes if it's harmless, it's reasonable to try. Heparin and aspirin together have been shown in some studies to be beneficial. And while it's not without its share of discomfort, there is really no damage from taking heparin and aspirin together. It doesn't really increase your bleeding significantly enough to make it harmful to you. Aside from the stinging and bruising from the heparin, you're generally okay. So I think it's worth considering. Immune therapy is the next one that they decided to tackle. This is a big topic. They actually don't say anything about it specifically, but they go through a bunch of different ones which they looked at. So they said there's very little data for IVIG therapy, intravenous immune globulin. We've just started using the subcutaneous in some patients. I think you really need to have data to show that there is an immune problem before you do this with the IVIG, because it is incredibly expensive. For the subcutaneous IG, I think it's reasonable in some patients to try, especially if they have a history that's consistent with this. Again, as long as they don't have any contraindications, it's very safe. They got to sit here for a couple of hours, let it infuse, and then you're good to go. They looked at intralipids, and they actually say intralipids may be hopeful. Now, this is interesting to me because we've been using intralipids for over 12 years now, and we do use it in the patients with failures, and I do believe that it actually works in some cases. So I think it's very reasonable. It's super inexpensive compared to some of the other crazy things like IVIG. And so it's really easy to administer. We've never had a reaction. Everybody does really well on it. You only need a couple of treatments, and we're only charging $250 for the first treatment, $200 after that. So it's very manageable for most of our patients. Other treatments that they've looked at, they looked at steroids. They say they don't know. They've looked at GCSF, which is granulocyte colony stimulating factor. They say it may be helpful, but again, they don't know. And so they're not sure about that one. And they basically summarize all of that stuff by saying they're not sure. They think more research is needed. So sum total, in terms of testing, essentially they're saying the only thing that you definitely should test for is your chromosomes. Although I disagree, I think that checking the endometrium for infections is reasonable, and I don't think that it's unreasonable to check patients for the thrombophilia screen for recurrent implantation failures. In terms of actual treatments, the intralipids and some of the immune protocols are very reasonable. There is data for aspirin and heparin, although these guys say it's research settings only to determine if it works. And the jury is out on whether or not you should do PGTA. Do not do the ERA test. Totally, totally useless. So this isn't necessarily fact or fiction, but each of those individual things can be a fact or fiction for you. So hopefully you've enjoyed sharing that information tonight. I'm hoping that'll bring some clarity to many of you who are struggling with the fact that you've tried multiple IVF cycles and it's not working. This should give you some answers as to what reasonable next steps there are, what you should consider doing, what you shouldn't consider doing. So thanks for joining us for that. That'll be up on the YouTube channel, www.youtube.com/drvictory, Dr. Victory. And as always, like, comment, subscribe. The more views we get there, the more it helps us to bring more of this entertaining and interesting stuff for you guys. So with that, I think we're going to take a whole bunch of questions. We did have one on our YouTube channel. which is how many IUIs can you do in your lifetime? And the truth is there is no limit to how many IUIs you can do, but there's probably a reasonable upper limit to what's effective. Once you go past 4, you're actually decreasing your success rate, and it shouldn't be done beyond that. So 4 is very reasonable. More than 4 is probably too many. There was another question on there too, Tark. Oh yeah, we had a patient that was asking about how to access Vizan in the US. I'm not sure how to access Vizan in the US. I don't think there's any restrictions on sending it. So if you want to contact us, I can look into sending it from here. But otherwise, you'd have to probably get it shipped from Canada. It's pretty safe. It's the most common progestin used in European birth control pills. So, and we've been using it here with no problems. Main side effect for about 10% of women is really bad headaches. Some women get hot flashes with it as well. Okay, let's take some questions. What are the success rate difference for embryos graded 4, 5, or 6, or 4 best? So there are so many different grading systems, it's tough to tell you. I actually was just looking at the newest edition of Fertility and Sterility today, and they actually said that once you are above a CC grade embryo, there was actually no difference in the outcomes if you knew it was genetically normal. So if the embryo is genetically normal, the grading actually is not that important unless it's like a really poor grade. If the embryo is not known for its genetic competence, we really still don't rely on the morphology of the embryo, the scoring system, because it actually has never been shown to make a huge difference. And there's so much variability. If I put 10 embryologists together and ask them to score the same embryo, you'll get a different response from each one. So one might think it's a 4, the other might think it's a 5, the next one might think it's a 6. There's poor, what they call inter-observer reliability. So embryo scoring is not a great way to tell if an embryo is going to be effective or not. Oh, I should stop sharing, sorry. I forgot all about that. Give me one sec, folks, while I skip back to here. Okay, so I'll take a few more questions from Instagram. So a bunch show up. So if the clinic had the inspection, is there a timeline for doing retrievals at the clinic? We're hoping by October they should give us permission. By the end of October, November at the latest. It should be fairly quick from here on in. We're anticipating getting the report. We respond to the report. We've already taken care of everything we had to. And then we should be allowed to proceed once they see that we've done everything they asked us to. So that should be all in very quickly. Good question. Would it hurt to take allergy meds before an embryo transfer? I've heard it can help with certain immune protocols. Yeah, there are people that believe in this H1, H2 blocker theory. So you take Benadryl and pantoprazole, and it's supposed to help. I don't actually think it makes any difference at all. We've had patients do it and it didn't make any difference for them. But it's not harmful. So again, if you want to take something to reduce your immune reactivity, it's probably not going to do anything negative. I think realistically, if you want to do something significant, you really need to take steroids, you need to take intralipids. Those sorts of things have a much stronger impact than taking Benadryl will. Okay. Hi, doctor. We just wanted to say thank you so much for everything you and your team do. We are so grateful and happy to say that you got us pregnant so quickly with our first IUI. Oh, my pleasure and congratulations. So that's an awesome little story. Thanks. I had a tiny piece of retained placenta post-labor removed via hysteroscopy and localized DNC 4 months post-labor. Wow. I had a healthy pregnancy and live birth from my first PGS-tested embryo. Retrieval was at 29 years old, now I'm 31. Doctor prescribed post-hysteroscopy estrace, 4 milligrams daily, plus Keflex, then Prometrium. Sure. Will this impact my future embryo transfer success in any way? I will be transferring an embryo from that same retrieval. Thanks so much. So yeah, it could. You really need to be very careful that there was no infection in the uterus. If you were carrying around retained products for 4 months, you actually should do that fertility test, because I can virtually guarantee you there will be something in your uterus, because dead or retained placenta is probably one of the #1 growth cultures for bacteria. So actually, that's a case where I would very strongly recommend you get tested by Fertility. And I'd actually go on a very long course of way more than just Keflex. You need Keflex and Flagyl, and you need to probably do that for a month, not just 14 days. So make sure you get that looked at because it can impact your success rates later. I'm 32 and had 3 PGT embryos not implant, trying to conceive for 6 years. Should I be paying for that expensive test at this point? Not if you're less than 38 years of age, never being proven to be beneficial. Having said that, if you had PGT tested embryos and they did not implant, then the question really is, why are they not implanting? And if they're not implanting, you really need to look at you. So that's the endometrium, your hormones, your uterus, your pelvis, endometriosis, all of those things. And yes, unfortunately, in some cases, we have to turn to using gestational carriers. So the one advantage of having the PGT tested embryos is it tells us that it was normal, and that eliminates a big variable when you're looking at reasons why something didn't work. So if you put in a PGT tested normal embryo, you're young like you are, Randy, and it's not working, you really need to consider why it wasn't working. It's clearly not the embryo in all likelihood. It's much more likely something about the lining of the uterus or your pelvis or your blood. So get that looked at for sure. Looking forward to my appointment with you next week. Me too. Looking forward to starting on this journey with you. 41, so praying. We will pray with you. I do every day, so I'm right there with you, no problem. Okay. What are your thoughts on IUI and how many should one do before moving on to IVF? So 3 of the same thing for maximum. So let's say 3 natural IUI or 3 IUI with pills like Clomid or Letrozole. And then if you want to move beyond that, you're doing the shots. And if you do that and it's still not working, then you need IVF. Now, would I do like 9 different IUI cycles first? No. I think realistically, if you've done somewhere between 4 to 6 cycles of IUI total, it's probably time to move on to an IVF cycle or something like surgery if they don't know why you're not succeeding with your IUI. I am still waiting on my hysteroscopy in Ottawa from my last miscarriage. Sorry, and can't do a transfer until then and have no idea when I will be able to have that surgery because of COVID. Hope throughout infertility, you can get treated at a out of hospital premises. So hopefully we'll have that soon. I don't know how long it's going to take for us to achieve that. It depends on how much the system costs. I'm meeting with the gentleman from the best hysteroscopy manufacturer very shortly, but they do it at Create. So you can have it done at Create, or you can have it done at a variety of different places in Toronto. Mount Sinai does office hysteroscopy. I know that Astra Fertility, Assam Michael, he has office hysteroscopy. So there are a variety of places where this can be done outside of a hospital. I don't know if they're doing it in Ottawa or not, but you may want to ask them if that's an option for you. You don't have to wait forever that way. What are your thoughts on IVF to do freezing embryos and no transfer until you can get hysteroscopy? Yeah, absolutely. Do your IVF, make your embryos. You should be freezing them anyways. Then do your hysteroscopy. That's a great use of time. That's from Hope Throughout Infertility as well. Absolutely, that's a great idea. Hello from Forever Love OS. I've been trying to order the test from Fertility and they seem to have trouble processing payments. Oh, it goes through on our end, but not theirs? I've not had anybody say that yet. So maybe reach out to them again and just see what they say, because it should work out okay. No one has complained about that. You might want to try a different card. Or a different, resource, maybe PayPal or TransferWise or something like that. Hey, Dr. V, all your staff is great, but I've seen Erin 3 times this past week, and she is so amazing. I just love her. She is so comforting, and I love how much she cares. So excited, fingers crossed. My fingers are crossed too, and thank you for all of the nice things that you're saying. So that's lovely. Appreciate that. Hi, I've had 4 transfers, 2 with my own eggs, 1 negative beta, and 1 miscarriage 8 weeks. 2, nope, don't show that. 2, what's that say? 2 WOR. So I'm not sure there's a question there, Stacy, but let me know and I will happily answer that question. So Stacy Ann on Facebook, let me know what the rest of it is. I'm sorry it hasn't worked. We definitely can chat about what to do. I need more details. What are your thoughts on how you can improve everything your ovarian reserve? And how you can improve your ovarian reserve? You cannot improve your ovarian reserve. Your ovarian reserve is related to how many eggs you have left. And because you can't increase the number of eggs, you can't improve your ovarian reserve. So sorry, unfortunately, that's a one-way ticket and you can't get it better. These lives are so great. I just wanted to thank you for your dedication and sharing your valuable knowledge with us. Thank you for watching. I appreciate that. That's great. Or can we transfer to you as our doctor at Create Clinic? Yes, you can transfer to me as your doctor at Create Clinic. I'd be happy to take care of you. And we can do surgery for you there for sure. Any suggestions on diminished ovarian reserve? I've tried everything and recently have been suggested to do supplements, micronized DHEA, and acupuncture. How about mini IVF, 39 years old? So everyone in the universe has their own opinion on diminished ovarian reserve. Personally, I think when you have DOR, there are some reasonable things to try which have evidence. So testosterone priming is the only one which has been shown to increase live birth. I personally use the microdose flare protocol. I like that. It doesn't mean it's better than any of the other ones. None of them have ever been shown to exceed any of the others or be better than any of the others, but it's a reasonable approach. The alternatives to this, or adding things that you can do, additional things you can do would be vitamin D, vitamin E, vitamin C, lots of antioxidants. Best treatment, aside from that, is actually to do natural cycle IVF, where you're just making the one egg you naturally produce, you go after it, you turn it into an embryo. Mini IVF has never really made a lot of sense to me. And the reason for that is you're paying almost the same as a full IVF cycle, and you're only getting 2 or 3 eggs. Why not just pay less, not go through all the shots, do natural cycle IVF and get one, unmedicated, essentially, egg or embryo, which some people believe actually improves the quality. I'm still not sure that's true. There are studies that show that it isn't. And certainly from a genetic standpoint, they've proven that it isn't. But it's still a reasonable approach to things. And it helps save you having to spend all the money on the shots, take all the shots, get all the pain and frustration. So I think it's something you should consider. I like the natural cycle better than mini. Otherwise, I actually recommend you just go for a full cycle. And of course, ovarian reserve is hugely critical. And if your ovarian reserve is really diminished, success rates can be poor. So under that circumstance, you really have to consider the value of using a donor. And it's not everyone's desire or wish, but you have to think about it. Hi, Dr. Victory. I had messaged you about IVF funding for Sarnia, and you said you would touch on it tonight. Just popping on to hear any updates, if any. Thank you again. We are working on it. We just allocated a couple of cycles. Next month, we'll probably have a couple more that we can allocate to the Sarnia Clinic for IVF. Not nearly as many as I would like. We are waiting for the government to respond to us in regards to funding for our whole Windsor program. I am very hopeful they'll provide us with funding, but right now we have not heard anything to suggest that they're going to do anything. It's just been an ongoing sort of discussion. So we are counting on them. Write to your MPPs or your MPs. Tell them that you want this. Write to the Minister of Health. Tell them that we need this funding. That's what's going to make it change. It's not going to be just from discussions. They need to hear that people want this. So that is the best way to do it. But we are getting as many cycles to you as we possibly can. Okay. Do you prefer to use heparin or Clexane? Yeah, MZ, we don't have Clexane as far as I know, so we use heparin. but we use low molecular weight heparin. So usually INA-Hep or Lovenox. Those are the go-tos for me anyways, and I like both of those. What is the likelihood of successful implantation if sperm count is low and DNA testing is suggested? Wow, that's an impossible question to answer. Great question, but impossible. I need to know what you're doing, IUI or IVF, and I'm not sure what you mean by DNA testing is suggested if you mean DNA sperm fragmentation. So very much depends on what you're doing. IUI with a really low sperm count, like 1 million, is less than 5% chance of success. IVF with a low sperm count can be a 80% chance of success. So it all depends on what's being done and how you do it. Okay. If you felt a few quote unquote symptoms after implantation, but haven't felt any in the past few days, is there any cause for concern? No, do not put any stock in the symptoms that you have, because every pregnancy is different. And that's kind of the magic of pregnancy. One woman, in fact, the same woman, might have a totally benign pregnancy the first time and then vomit through the entire pregnancy the second time. And so every pregnancy is different. Do not put any stock in your symptoms. It's important to stay positive. It's important to stay hopeful. You have to do that in order to kind of feel good about the whole process and actually improve your success rates. Will eating pineapple core improve implantation? And can I take baby aspirin alongside while I eat pineapple core? So no one knows if pineapple actually improves, but people believe it does. And yes, you can take aspirin while you're taking pineapple core. That's fine. It's hard to eat pineapple core. It's so tough. I haven't tried pineapple core in a million years. Do we need a doctor's referral to see you? Yes, unless you're coming directly for IVF or you're not in Canada. If you're not in Canada, you don't need a doctor's referral. You can reach our office through the website or directly 519-944-6400 or info@drvictory.com. Otherwise, if you're in Canada, yes, get a doctor's referral and we'll make arrangements to see you. And yeah, absolutely, I give second opinions to people pretty much every day, all the time. Lots of people come to us because we're really good where everybody else has failed. So not only do we do a good job the first time, but we do a good job when it's your second try and the first one wasn't with us. I have a question, but don't know if it's okay to ask. Here we go. I've been so bloated lately and it looks like I'm gaining weight and I don't know how or what's going on as I barely eat sometimes. I read endometriosis makes you bloat, but this much is what I'm wondering because it's driving me crazy and my periods lately have been more painful. Went to the emergency department not long ago and they said I had a cyst and I still don't know if it's gone or not. So yeah, I mean, endo can cause bloating for sure. So can your bowel symptoms, and if you have endo on your bowel, it really causes bloating. But endo bloating is not usually severe abdominal bloating because endometriosis, unless it's actually on your bowel, shouldn't be causing that kind of problem. So if you're having bowel trouble or a lot of gas or bloating, make sure you see a GI specialist, gastroenterology specialist. For sure, you can try medications that suppress the endo and see if it makes your bloating go away. If it does, you know that that's the culprit. And if it doesn't, then obviously that's not the case. And you got to look for other possibilities for your diagnosis. How many days past ovulation would it take for a urine pregnancy test to pick up any HCG? At the very, very earliest, somewhere between 11, 12. Some companies say with a low success rate, they can do it at 8 days, but that's really, really early. Even in blood, you usually can't pick up till about 8 days after ovulation. So urine tests would be pretty tough. 11 days you possibly can. We were in the process of trying to collect urine to finish a video we have testing different kits, and we got to finish that video, but I need to get someone's urine who tests positive for pregnancy at 11 days, and we haven't done it yet. So we'll let you know as soon as that video is up. I got to remind Kim. Kim, if you're watching, we need pee. Story, I mean, do you prefer INA-Hep, Tinzaparin, or Clexane, and Enoxaparin? Yeah, so Enoxaparin, we call Lovenox. Yeah, they're all fine. It doesn't make any difference. They're the same. None of the low molecular weight heparins make any difference. Does HCG help? Does HCG wash help with recurrent implantation failure? Possibly. HCG wash does increase success rates. We've started doing it with reasonable success. So yes, I think that that's a reasonable thing to do. I would definitely consider that for anybody that's doing IVF. Can your AMH go up? I had an AMH done in September 2017. It was 30, and I just had it done again. It was 33. Well, your AMH is really high to begin with, and that's probably lab error, those margins. But typically it doesn't go up. When your AMH is 30, though, it doesn't matter because you've got a high AMH, so it's going to stay high either way. You have recommended my husband have a sperm DNA test. Not sure the exact name. It's sperm DNA fragmentation testing. Curious what is determined in this test. Also, what supplements can be taken to improve sperm quality. So along the strands of DNA, the double helix, so like a ladder twisted and twisted, there are breaks in the DNA. And the more breaks that you have, the more fragmented the DNA is. And that has been associated with poor outcomes, especially in terms of miscarriage risk. So we're testing to see how much breakage there is in your husband's DNA. What fixes it? A lot of vitamins and getting off of everything bad. So if he's a smoker, a drinker, a drug user, anything like that, marijuana use, obesity, toxin exposures, lots of plastic bottles for water and juices and pop and so on, you got to get rid of all that stuff. Healthy diet, lots of veggies, lots of vitamins, lots of fruits, get rid of the bad habits, exercise, low cholesterol, that kind of thing. That can improve your sperm DNA fragmentation. You got some there? Yeah, go for it. We got some questions from earlier. Tarek's going to ask.
We did the IUI one.
Yeah.
Somebody else asked them as well. How many failed embryo transfers become concerning, fresh and frozen meds and that?
So how many fresh and frozen embryo transfers become concerning? It depends again on your program. With me, if you fail 2, I feel like something's wrong because we really pride ourselves on being very good. So if you failed 2 embryo transfers, I got to start looking for reasons why. But it's program dependent. Again, if your program only has a kind of typical 35% success rate, I mean, that might take 5 or 6 embryo transfers before you start getting worried. So it very much depends on what the success rate in your program is. But with us, I start looking for a reason for failure after 2 failed transfers.
What is estradiol used for prior to IVF? And Downey really needed no endo, no PCOS.
So the question is, what is estradiol or estrogen used for prior to IVF? The only reason to take estrogen prior to IVF is estrogen priming, which is thought to help improve the number of eggs you can produce. Again, it's one of those things that's never improved live birth rates, but a lot of people do estrogen priming. I think it's kind of being supplanted by testosterone priming now, which does seem to help a little bit, even with live birth rates.
Will Clomid help me ovulate on my fallopian tube side? I have one tube due to an ectopic PG.
So the question is, will Clomid help you ovulate on one side versus another? And the answer is no. But Clomid typically will make you make more than 1 egg, maybe 2 or 3, and often there will be eggs growing from both sides. So there is probably a higher chance you'll ovulate from both sides, but it's not side specific and there's no way to guarantee it.
How much does embryo grading matter if it's been tested as PG as normal?
It doesn't. So if your embryo is tested as PGT normal, it's a euploid embryo. Your embryo grading does not really matter. And as I mentioned earlier in the show, the newest edition of Fertility and Sterility has an article on that shows that it's only when, the grading of your embryo is less than CC in that grading system that it becomes a problem.
Semen washing question, and what's the cost?
How much does it cost to do a sperm wash? When we have funding, $350 for a normal one, $450 for the one with Zymo. Now that we don't have funding, it depends on what kind of IVF you're doing. Anywhere from a minimum, IUI you're doing, minimum of $650 up to $1,175, because we've run out of funding from the government despite asking 100,000 times for more funding. So we're trying really hard to get that. Let me take a quick one from here. Would you suggest doing the AMH test to know what the ovarian reserve is? My doctor doesn't seem to advise it. 100,000,000%. AMH should be a standard part of your fertility workup, because if your AMH is compromised, you may need to hurry and get pregnant and be much more aggressive than when your AMH is sky high. Yeah.
Do yeast infections negatively impact success of embryo transfers, natural conception?
So no one's ever shown that a yeast infection outside of the uterus has impacted embryo transfer success. But if you have a raging yeast infection, you're not going to do an embryo transfer, obviously. So I wouldn't. However, finding yeast in the uterus, which that Fertility test does, almost certainly will. So we do advise you to get tested for that if we think that that's a concern.
I recently miscarried and I was told that I would be put on progesterone right away for the next pregnancy. How early would I start taking it? When we start trying, or when I get a positive test? I'm not currently receiving any fertility treatments or assistance except for taking letrozole during my cycle.
Sure. So this question is about timing of progesterone for someone that miscarried previously, if you guys couldn't hear it. So the answer to it is you need to take your progesterone the day after you've made the embryo. So if you use an ovulation predictor kit and your ovulation predictor kit is positive today, you're going to have sex tomorrow to make the baby. And the day after that, you're going to start your progesterone. If you start it any earlier, you just took birth control. It's actually going to prevent you from getting pregnant. And if you start it too late, it's actually useless. It doesn't work. So timing of progesterone is critical to the efficacy of progesterone.
Do you recommend women to have an ERA?
No, I said that already 1,000 times. Do not do ERA. ERA is useless. Every study done, including 2 more that were just released or are about to be released, have shown that there is no benefit to doing an ERA test. The ERA test categorically proven to be useless. Do not do an ERA test.
How many days after ovulation does it take for a urine test from Life Labs to detect?
I answered that one.
Oh, you did that
one?
Okay.
Yeah.
Okay.
If you've had 2 follicles before IUI trigger shot, do you find most have twins or 1 pregnancy? No, you'll still find 1. So there's no increase in twins with just 2 eggs. There is an increase in twins when you have 3 or more eggs, but there is no difference in twinning rate with just 2 eggs, interestingly. So you're safe with 2. Thanks for answering all the questions. You're incredible for this community. My pleasure, no problem. Hi, Dr. Victory. Just wanted to know if taking our temperature when at a higher number is good for when trying to conceive. Just wanted to know if taking our temperature, don't take your temperature. I'm going to answer this the simple way. Temperature monitoring is useless. Just buy an ovulation predictor kit and use the ovulation predictor kit. It is way more accurate than taking your temperature. Taking your temperature can be confounded by all sorts of things. How thick your blanket is, how sweaty you are, how close were you to your partner while you slept. Are they hot? Are they cool? Like, temperature monitoring is useless. Do not do temperature monitoring. Just use the P stick where you test for your ovulation, and that should answer it for you. Do you recommend an ERA? Sorry if you've already answered this. No, I already answered that one. I think I did it. I answered all the questions. Does anybody have any other questions? Because we are out on our various social media platforms. If you have any, by all means, I'm happy to answer anything else anyone wants to ask. Otherwise, we can wind down a few minutes early tonight. I think we got everybody we needed to.
Did you answer, would you recommend trying IUI, or are the odds extremely low with endometriosis?
Oh, no, I didn't answer that. So the other question is, would I recommend trying IUI, or are the odds low with endometriosis? So no, IUI is still reasonable in cases of endo. It's not as good as IVF, but it's still got a reasonable success rate. There is no reason not to try. Someone's telling me to hold on. That's cute. I will hold. We'll stay until 9, guys. Do you have any other ones?
Do you think with some stims and IUI, we could possibly avoid IVF altogether?
Yeah. I mean, we actually insist that our patients try 3 IUI before we put them on the government-funded list for IVF, because a ton of the patients get pregnant and skip needing IVF, which keeps at least the list down for those that really desperately need the IVF. It's long enough already. We don't want to make it any worse. So we definitely recommend that you try IUI first if you are eligible for IUI. So obviously, if the sperm is severely compromised, the woman's tubes are blocked, there's severe endo, or age is really advanced, you're 39, 40, 41, 42, IUI may not be the best choice. But it's always a choice unless the tubes are blocked. And so it's worthy considering your movie recording stuff. I'm in USA. Our border's still closed, yes. I lost twins at 20 weeks. Oh my gosh, I'm so sorry, dear. 1 full-term pregnancy, lost at 14 weeks. I lost at 6 weeks PGA tested. Surrogate lost at 4 weeks. Wow. I have 6 PGA tested normal, 42 next month. I have transferred 9 embryos, 3 PGA normal. My clinic only wants to transfer 1 embryo. Would it be okay to transfer 2 embryos? I wouldn't transfer anything until they figure out what's wrong. That is not normal to have that many embryo transfers. You need to see a reproductive immunologist, and you need to do that fertility testing. That's for Veronica. Do not transfer any more embryos until someone gives you an answer. You probably need surgery. You need evaluation to see what's wrong with the lining of your uterus, with the pelvis, see if you have endometriosis, adhesion, scarring. Maybe your tubes are damaged. You absolutely need to get that figured out. If you lost twins at 20 weeks, I would also strongly encourage you to have a full evaluation of your cervix and your uterus, because that very much sounds infectious. Do the fertility testing. I'm willing to bet you that you're going to find that you're positive for something and you'll solve your problem. Is there anything you can do for AMH levels? No. What is considered a really good sperm count? Well, the minimum is 15 million. 40% have to be swimming. You need 4% normal, but that's according to the strict criteria. If you're not following the strict criteria, probably 50, 60% should be normal. And you want them to be moving quickly, which is a score out of 4, and you want 3 or more. So there's 3, 3+, and 4. So minimum 15 million, those are the World Health Organization criteria. Most of us actually like seeing even more sperm than that. We know from a recent study, you need at least 14 million sperm in your IUI to get a reasonable success rate. So that's really important. IUI this morning, timed intercourse tonight or tomorrow? Tonight. As many times as you want, but tonight, definitely tonight. Okay, I got time for maybe one more quickie. Anybody got a quick question? You got one there?
No.
Okay. All right. Well, I think we'll wind it down then, folks. So thank you for joining us as always. And done. So thank you for joining us. I am glad that you guys were there. Krista Harvey, Vizan in USA. I am not sure if it's available there or not, but contact me through our office and I'll see if I can get you some. So call our office or email info@drvictory.com and we'll get back to you and see if I can get you some. Have a great night, guys. We're going to get cut off in a second. Back again next week. Hope you enjoyed the show. Tell your friends. Tell everybody you can. The more we blow this up, the better it is. So have a great night. We hope you have a good week and stay safe. Hand washing, isolation, social distancing. Make sure. Take care. Bye now.